Welcome, everyone. My name is Siam Rezwan. I'm the chair of the Global Health Leaders Conference, and today we are very happy to have Dr. Joshua Sharfstein. To introduce Dr. Sharfstein, he is the director of the Bloomberg American Health Initiative, vice dean for public health practice and community engagement, and professor of the practice in health policy and management at the Johns Hopkins Bloomberg School of Public Health. Previously, he has served as a secretary of the Maryland Department of Health and Mental Hygiene, the Principal Deputy Commissioner of the U.S. Food and Drug Administration, and as Commissioner of Health for Baltimore City. Dr. Sharfstein is also a co-host of an excellent podcast called Public Health on Call, which has been downloaded over 5 million times. Throughout the COVID-19 pandemic, he has done a phenomenal job in bridging the gap between experts and the public. Today, I'll be interviewing Dr. Sharfstein surrounding some of the questions many of you submitted on the COVID-19 pandemic. Dr. Sharfstein, thanks so much for participating in our Global Health Leaders Conference at Hopkins this year. It's great to have you.
It's great to be here again, and certainly would encourage anyone who is able to turn their camera on to do so.
We'll go ahead and start by addressing a common question many students had. With respect to where we are now in this pandemic, what are the next stages in putting this behind us in the United States? And how close do we seem to be in our return to pre-pandemic normalcy?
Thanks for the question. And boy, what an incredible year this has been. And I know for many of you, probably all of you, this has been incredibly difficult. I think everybody experiences the pandemic in a different way based on where they are in life. And for young people in high school, you know, you were cut off from your friends. You couldn't go to school, most of you, if not all of you, for a good part of the year. And also, you know, you see people all around you suffering, many of them quite seriously. You may have had family members die from COVID or be seriously ill. And it just seems so unfair, which it is, and so arbitrary, which it is. So, you know, I think that you'll look back on this time and have to kind of process what happened and think it through. You know, you're very resilient, and you'll bounce back faster than you could possibly imagine. But at the same time, I do think it's important to recognize how traumatic the year has been. So, you know, the United States is in a different position than many other countries in the world because of having ready access to safe and effective vaccines for the whole population. And we're seeing, you know, dramatic declines in the number of cases, hospitalizations, and deaths in this country. And, you know, one thing that you learn in epidemiology is that when infectious diseases spread, they can spread exponentially. So it's like, you know, there used to be an advertisement, you know, and they told two friends, and they told two friends, and they told two friends. And so like a rumor can spread 1, 2, 4, 8, 16, 32, 64, exponential growth. That's what happens when people are basically infecting other people. But in a way that reverses, and you can see very dramatic declines in the number of people infected when you get to a point where the virus doesn't really have that many places to go. So that's what we're seeing in the United States. In terms of getting back to normal, I think what the projections are is that we have enough people vaccinated in most parts of the country right now for cases to really bottom out and probably stay low for the summer. However, in most places, we don't have enough people vaccinated to prevent another surge in the fall, particularly among people who are not vaccinated. So the estimates from some modeling, and maybe I'll be able to put this in the chat if you're interested in seeing it, the estimates are that you need about 80% of people to be vaccinated to really be confident that you're not going to have another surge in the fall. So the United States is not out of the woods, although I think it's going to get better for at least the next few months. And vaccination is probably the single most important thing that will make the difference. You know, in other countries where there's not access to vaccine like there is in this country, one of the most important things is to have access to vaccine. I think there'll be a lot of lessons for global vaccination from this situation that we're in now. And where there is not access to vaccine, to be very, very careful and, you know, take all kinds of precautions. Probably the most important one is to wear very, you know, high quality masks when engaged with other people. But there's a lot of other things that come into that question still. And the virus is as you know, mutating, and there are different variants, and some of these variants are quite infectious, more lethal, including more dangerous for young people. So it's just really important for everybody still to be careful in areas where there's not that kind of access to vaccination.
We'll now move on to vaccine development and vaccine hesitancy. Would you be able to walk us through the typical process of vaccine development and the much more rapid process for COVID vaccines, and why there should or should not be any concern for the safety of these vaccines?
Sure. So typically there is a process for vaccination where you do phase 1, phase 2, phase 3 studies before making a decision about having people take the vaccine. And the phase 1 study is basically in healthy people to make sure that they can tolerate the vaccine. And the phase 2 study is to look at the immune reaction to see whether they have the kind of immune reaction you would expect to a vaccine that you think would protect someone from the vaccine. And then the phase 3 study has a lot of people, often thousands and thousands of people, to see whether it really does protect someone from the vaccine. And it's important to do that last phase study because you can predict based on an immune response, antibodies, that it should protect someone. But sometimes when they actually do the phase 3 study, they find out that it's worse and it doesn't protect someone or might actually make them more sick. So it's important to do that phase 3 study to really understand. Now, typically what happens is that each of those phases is separate. So if we were going to do a vaccine against, some pathogen, we would say, okay, let's say we're a company. Let's raise money for phase 1. And we go out and we try to raise money for phase 1. We'd say, we think this is a great idea. We want to do a phase 1 study. And then we would do the phase 1 study and we would look at the results. And if it looked good, the vaccine was well tolerated, then we would go back to the funders and say, okay, now we're ready for phase 2. And there'd be a period of time between phase 1 and phase 2 before you start the phase 2. We might not even spend money to plan the phase 2 until we knew how phase 1 would go, because we want to make sure that we don't have money to plan the phase 2. We got to take care of job 1, which is phase 1. So what you see in normal vaccine development is a lot of time between the phases. And if you think about that third phase, which could have tens of thousands of patients, you're not going to start planning that until the phase 2 study looks like it's good. So there's just a lot of time there between phase 2 and phase 3. And then you have manufacturing. You're not going to make a vaccine, millions of doses, until you know that it works, which is phase 3. So typically it's phase 1 space, phase 2 space, phase 3 space, and then manufacturing capacity. And it can take years to scale up manufacturing capacity. So now let's talk about COVID, what happened. In the United States, the government said, we are ready to spend billions of dollars to get these vaccines made fast. And said to the companies, we don't want you to go 1 phase space, 2nd phase space, 3rd phase space. We want you to start them all at the same time. So do your phase 1. In fact, they kind of looked at both in the first part. They looked at whether it was tolerated and immune response at the same time. And while you're doing that, start planning your phase 3. Now, we're not going to do a phase 3 study until we know that it worked in phase 1 and phase 2, but we're going to be ready right away. Like the moment we decide that it's good to go, we're not going to have to go out and raise money and wait and plan. We're going to have all these clinical trial sites ready to do a phase 3 study with tens of thousands of patients. So they basically took out the spaces that normally exist. That's how we got this fast. But the type of data we got from the phase 1, phase 2 study is the same as we usually get from phase 1 and phase 2 studies. And that phase 3 study for the US vaccines was enormous. They were tens of thousands of patients in each arm randomly assigned with meaningful outcomes of getting ill with COVID. And they were tracking serious illness and death as well. And so they did the usual study, but they started it all fast. And then with manufacturing, they started the manufacturing of millions of doses before they even knew that it worked. That would never be done. If it turned out the vaccine didn't work, they would have just tossed it. They would never have used it, but they put all that money in first in order to just get everything going so that there was just no space between the different things. The one other major difference is that typically the FDA in the United States, the Food and Drug Administration, will wait for 6 months of safety data before doing a license for a vaccine. And so that would mean, since they started the studies maybe back in September, that it would be March before they would really be starting to look at the data for a license. But what they did was they said, okay, typically we do 6 months, but when will we really see the adverse effects of a vaccine? And what they realized is there are two kinds of adverse effects that they would expect to see. Some are immediate, very soon after vaccination. And they would do a lot of surveillance in the first week to know whether people got adverse effects. But then the second most common kind of adverse effect is a little bit delayed when the immune system kicks in, and that's 1 to 2 months. So they said, okay, we're not going to license a vaccine until 6 months of safety data, but we will authorize a vaccine. We will allow it to be used with 2 months of safety data, based on our understanding of the fact that we would expect the adverse effects to show themselves in the first 2 months. And so that's what the policy was, and that's why it was authorized and not licensed. And now that more time has gone by, Pfizer has submitted for a license in the United States, and I'm sure Moderna will do that too. So we'll have licensed vaccines very soon, not just authorized vaccines. But in general, the feeling was there's absolutely the same amount of data on effectiveness, a little bit less data on safety, but we have every strong reason to believe that this is going to be, there's not going to be any surprises with just tens of thousands of patients between 2 and 6 months, and that's actually been borne out. In terms of, there's nothing that's popped out at 2 to 6 months later that would have, been an issue. So that's really why it happened so quickly, and it's why a lot of people who know the process, like me, ran out and got vaccinated because as soon as we could, because the evidence for this was so strong. And one last thing just to mention: how do you know whether a vaccine works? Well, they give the vaccine to tens of thousands of people, 40,000 in these studies, and half of them got the vaccine and half of them didn't, and they didn't know which one. So if you were in the study, you didn't know whether you got the vaccine or whether you just got a placebo, nothing, like saltwater injection. And so you're walking around, you don't know. But if you get sick, somebody writes that down, and they don't know whether you got the vaccine or not. And then every so often, there's some people back at the headquarters for the clinical trial who look when there were 100 or so people who got sick. They look to see, well, how many of those people were in the vaccine group versus the placebo group. And if they had looked and it was 50-50, then the vaccine doesn't work. And they were hoping that it might be more like 70-30, but what they got for the mRNA vaccines, for the Pfizer Moderna vaccines, was more like 95-5. 95 of those infections were in people who did not get the vaccine, and only 5 were in people who got the vaccine, and that's how they knew that it worked.
So we all recognize that vaccines are key to end this pandemic. However, vaccine hesitancy seems to be a significant issue for building herd immunity, especially in the United States. Could you explain to us some of the arguments or reasoning that you have heard from people who are hesitant or do not want to get the vaccine, and what your response would be to these concerns?
Sure, and I think it's important to think about vaccine hesitancy with 2 dimensions. One is how much people want to go out and get vaccinated, and the other is how easy it is for them to go out and get vaccinated. So some people are like, definitely want to get vaccinated, but they can't get to the vaccine site. So they're not that, hesitant in the traditional sense, but they're still not vaccinated because they just can't get there, or they're homebound, or for whatever reason, they couldn't use the internet, they don't have people to help them, they don't know where to go. So you bring them vaccines and boom, they get vaccinated right away. Then there's some people who, it doesn't matter if you bring it to them on a silver platter, they don't want to get vaccinated because they just don't want to get vaccinated. And there are a number of different reasons why people fall into that category, and you may know some in your own lives. Sometimes people have a deep distrust. Sometimes people are just scared of putting something in their body. Sometimes, right now, there's an enormous amount of falsehood on the internet. People might read it and say, "Oh, I think I won't be able to have children or something." That is completely untrue, but they read it on the internet and they get all caught up in it, and so there are a lot of different reasons why people have that. I think one of the ways to approach this is to realize that there are these two dimensions, and it's both about helping answer people's questions and be respectful and listening, and about making the vaccine more available to them in trusted places. So I'll give you a specific example. I live in Baltimore City, Maryland, in the United States, and my wife is a doctor. We met in medical school, and she works in addiction medicine. She takes care of people who have an addiction. And a lot of these people are quite high risk for getting very sick from COVID. But a lot of them are also not vaccinated. And they couldn't, or they didn't want to go and stand in line and get vaccinated at the usual places. So my wife's clinic started offering vaccine. And what she found was that a lot of people who were coming, first of all, they wanted the vaccine, they were willing to take it, but also they hadn't been vaccinated, even though some of them were older. They were like over 65 or 75, believe it or not, and they hadn't been vaccinated. And she would say, "Well, why?" And they said, "I just didn't want to go there. I feel much more comfortable getting vaccinated from you." And there are community health workers there who can answer people's questions and relate to them. So I think the solution is to be patient and think about ways to talk to people, answer people's questions, but at the same time make it more accessible at places that people trust. Some of us, like me, I'll drive an hour to get vaccinated. I'll walk through I'll walk through a snake pit to get vaccinated. I was really worried about COVID-19, and I had a lot of confidence in the vaccines. But I know other people aren't like that at all, and it's just got to be more accessible in places that they understand to get vaccinated. I mean, I'd be wearing boots in the snake pit, just for clarity.
As you mentioned, a major challenge throughout the pandemic seemed to be the significant amount of misinformation, especially on social medias. From what you have seen and done yourself, what have been some of the successful ways to combat misinformation during the pandemic?
I think that that's still being worked out. I think that it is important, I think, for these social media platforms to flag or sites or take down sites that are just spewing lies about vaccines, because I think it can be hard for people to really distinguish between good sources of information and other sources. So flagging it and saying this is not true and here's a better source for information can be helpful. I'm also worried, though, about kind of the algorithms that social media sites use, that if you watch one, post that is like skeptical of vaccines, then before you know it, every time you click into that social media, that you're being offered up new, skeptical posts, and then it just sort of leads you further and further and further away from good sources of information. I think that that's not good. So, I think that it's both sharing good information and trying to reduce the sharing of bad information that's important.
So one thing that was quite surprising to me during the pandemic was what seemed to be the politicization of public health behaviors, such as mask wearing. Do you have any observations or thoughts on how this seemed to happen, and what can be done in the future to limit the interference of politics on public health behaviors? Or will there always be politics in public health behaviors?
Well, politics in public health and crises and pandemics, there's a history of that goes back a long way. Long way. So there's, a great book, and maybe some of you have read it, is The Plague by Albert Camus, which is about a smallpox outbreak. Actually, I think it's a smallpox outbreak. And it is just, it might not be smallpox, but anyway, it's really integral discussion of how politics influence the response and what's actually happening within the society. And I totally, if you go back to the 1918 pandemic flu in the United States, there was an anti-mask wearing league, and people were, fighting with their fists and weapons about mask mandates. So there's something that is very difficult about pandemics. People have a lot of fear. They have a lot of distrust. Generally, it just basically awakens people's primal instincts, and you put public health in the middle of that, and you wind up with a lot of danger. Now, we don't see that the same in every society in the world, right? You don't see the same kind of aversion to mask wearing in the United States, for example, as you might see in South Korea. South Korea experienced SARS in the early 2000s, and there's just a much greater understanding of the value of masks, and people don't consider, may not consider wearing a mask quite the same way as some in the United States. So you have sort of different cultural perspectives, and then on top of that, you have different politics. So it could be that in one particular country, the leaders of the different political groups get together and say, well, we're going to collaborate on this. And many parts of the world, they did this. And we all believe that wearing masks are a good idea. But in the United States, that's not what happened. One of the political parties decided that it would sort of weaponize mask wearing and kind of belittle people who wore masks. And that, amplified the people and the concerns that people had about wearing masks. So I think some of it may be inherent, and then some of it may be exploited during the crisis itself. And it was definitely one reason why the response was so difficult in the United States, and frankly, so many extra people died who didn't have to.
Shifting focus a little bit, with a challenge such as this pandemic, as you'll probably agree, not only highlights our strengths as a nation and society in tackling a common issue, but also exposes our weaknesses. What do you feel have been some of the most significant issues or inequities that this pandemic has revealed in the United States?
Sure, it's a really important point. And, pandemics in the United States and elsewhere exploit all of the weaknesses of society in many different ways. It certainly exploits the political polarization, just as we talked about, and also exploits just the vast gaps in access to resources, finances, social capital that exist in the United States and other countries. So we saw in the United States that certain communities, particularly communities of color, were more likely to get COVID in the first place and less likely to get tested for COVID. Why were they more likely to get COVID? Because they might have been more likely to work in jobs that were essential workers without protections. They were more likely to live in overcrowded living spaces, things that really were fundamental to social support. They didn't have it. They didn't have protections under the law, and as a result, they got sicker. And then when they got sick, less likely to be tested, and in many places more likely to have serious adverse outcomes. And that reflects inequities in the healthcare system. Some cities, many cities, have a differential hospital system, even in the United States, for people of different economic backgrounds, for example. And so you had some hospitals that were just overwhelmed, and other hospitals that were able to go out and buy all kinds of supplies and provide a different level of care. And so I think every level of inequity contributed to the inequities that we saw. Now, there's something that I found very interesting during the pandemic in the United States is when people talked about the differences in death, for example, between people of different races and ethnicities. They often talked that there was like this percentage of the population and this percentage of deaths. So maybe, a group was 14% of the population, but 20% of deaths. And it seemed like, okay, that was about maybe a third increase in the risk of death. But epidemiologists will say that's not actually the right way to do the comparison. And that's because the population distribution is different for different groups. And in particular, in the United States, white populations are older. And African American Latino populations are younger. They skew younger. So what that means is if there is an increased rate of death in African American or Latino populations for a disease that strikes older people more heavily, like COVID, then it's actually much worse than that statistic appears. And when you do something called age adjustment, you create a standardized age distribution, and then you compare between the races. And when you did that, the rate of death for most of 2020 was actually 3 times higher, not a third higher, 3 times higher. And that's why when they looked at life expectancy declines, the life expectancy declines were so much greater among African Americans and Latino Americans compared to white Americans because of the age distribution issue. And so even people who were trying to make a point that there was unfairness, they weren't citing the right statistic. You really have to do a standardized age. And that's the typical way that epidemiologists do this. For a long time, the CDC itself was not putting up the age-adjusted differences. And finally, in December, they did that. So I think that we have been underappreciating the vast inequities that have been revealed by the pandemic.
And as we know, pandemics can certainly happen again in the future. So my final question before we open it up to the students is, in your opinion, what has been one of the greatest strengths of our global community that the pandemic has revealed? And what are some things you believe should be done to prepare for the next pandemic?
So I think that one of the most important things was that the scientists were collaborating early on across the world, and that we were able to use cutting edge science very quickly to develop vaccines in record time that have saved millions and millions of lives already, or will save millions and millions of lives, I should say. That's probably one, very big one. I think that there's a lot not to like in the way that countries nationalize the response. But I did think that there was a lot of learning between countries about different strategies that worked and didn't work, a lot of sharing of scientific information. And I do think, to your second part of your question, what happens next is really, really important. And I teach a class at Johns Hopkins, and I wrote a book about public health crises. And one of the lessons of public health crises is that a lot can change after a crisis, but it also doesn't have to change. Some crises lead to just transformations of policy in different areas. And I'll give you an example. There was a crisis about a poisoned medicine in the United States that led to the entire system we have now of making sure that medicines are safe and effective, and vaccines. Had that crisis not happened, and had they not really pushed for a total change in the law, the establishment of the Food, Drug, and Cosmetic Act, none of that would have happened. That crisis had an enormous long impact and cast a shadow a century later. Other crises, though, can be massive, but then people just really want to go back to normal. They just want to put it all behind us. Let's just go back out again and have a good time and forget about what happened. So the question, which is a natural instinct, frankly, so the question for this pandemic and this crisis is, which is it going to be? Are we going to just sort of snap back to where we were before? Are we going to learn some of these lessons for science, for equity? Are we going to invest in sick leave protections and better housing and things that really made people die, frankly, during the pandemic? Or are we going to just say, wow, I'm glad that's behind us, on to 2021? So I don't know the answer to that. But I think that this is really the time. And I'm spending a lot of time trying to get people to, think about that, and to get the Congress of the United States, the president and the administration and other countries to be really thinking strategically, not just about a particular vaccine platform or a particular testing platform, but really about the kind of public health structures that we need to be much more resilient for whatever comes our way.
Thank you, Dr. Sharfstein. We'll now take a few questions from the students. Students, if you do have a question, please use the raise hand function, turn your camera on if possible, and I'll call on you based off of the order my Zoom is showing.
Hi, first of all, thank you very much for this. This was very interesting. And I was wondering, what's your opinion on the removal of the mask mandates that are going on across the country? And what's your advice for people who are vaccinated? Do you think that they should continue wearing masks, et cetera?
Great question. So I think, let's talk about for individuals who have been vaccinated. The CDC has looked really closly at the evidence and feels like individuals, just a flat statement, are going to be pretty safe not wearing masks, certainly around other people who are vaccinated, and the CDC thinks even around people who are not vaccinated. There's still a chance that you could get sick, but they view it, well, it's going to be almost certainly a mild illness. Very, very low chance of a severe illness in that situation. Now that's so that's sort of the advice for people with regular immune systems who have who get a vaccine. That's for individuals. Now, that's a little different than your first question, which was, what do you do about a mask mandate? Because society has people who are vaccinated and not. So it's not just the same as, well, what if everyone were vaccinated? One way I think about this is, imagine that you had a program you could put in your car that would allow you to go right through the intersection on a red light and you'd never hit anybody. It would just notice where the other cars were and just go zooming through. Well, you could have a report from the CDC saying, yeah, this computer program actually works. But that doesn't mean people will get rid of traffic lights, because some cars have the system and some cars don't have the system. So what do you do? I think when the CDC explained its advice for individuals, a little something was lost, that they didn't necessarily mean it to get rid of mask mandates, particularly in areas where there is a lot of COVID. So my view would be, while there's still a high rate of COVID, a reasonably high rate of COVID in the community, indoor mask mandates are still a good idea. As that number of cases goes down, then at some point, you could switch and say, we just want people who are not vaccinated and kind of a little bit rely on the honor system, but it would be doing that with a pretty high degree of safety because there's so few cases out there. But while there's still, a fair amount of transmission, I would go with the mask mandate, and I would say to people who are vaccinated, well, maybe you don't have to wear maybe it'd be okay for you if you didn't wear a mask, but for society, we need everyone to wear a mask so that we can enforce it and keep people safe, just like we might tell people with that car, maybe you could make it through that intersection, but we really need people to stop at a red light now because there's so many people who don't have that program in their car. I would say people who are immunocompromised, who are transplants, they need to keep wearing masks and be careful.
So part of the thing you brought up was the idea of how social media was really affecting vaccine hesitancy and in general maybe causing some of the issues we saw during the early stages of the pandemic. I'm not sure if you've seen this docudrama known as The Social Dilemma, but in it really goes in depth about how social media really manipulates its algorithms and maybe presents false information or promotes alternate groups that may be against certain things such as vaccines and mask wearing. Do you think it's more of the government's role to tell social media that you guys really cannot be doing this, or do you think it's more of a public standpoint that the public should really stop using such social media, or do you think it's really up to the social media companies to say, we have a moral responsibility to not present all this information?
So I'll tell you my own view, although I don't think it's any more valid than any of your own views. You may be more avid users of social media than me. I think that there's something very important for the entire society in what's happening with social media. And I don't mean that just for COVID. I think it's also true for democracy and other very important things that we need in the United States. And I think that these should be public decisions. I don't think for any reason that just because you started a social media company, you have the special ability to figure out where to draw the line, and nor would I necessarily trust someone in that situation. So I do think that this is an area that needs to have a full public discussion, and we should come up with policies that make sense and can balance the various challenging interests involved. It's really important to have a diversity of views. It's really important for there to be freedom of expression. But there's certain things that really cross the line to misinformation, falsehoods, put people's lives at risk. And where to draw the line there is not an easy question. But I would personally trust a public process more than I would just somebody because they started a social media company.
My question is, so like I've heard a lot of mixed things about if we're gonna have to wear masks in school next year and like with sports. And like I was just wondering like what your take on it is for like high school specifically, and also like contact tracing things. Cause I know with my school, we'd sometimes have half our class out because one person got COVID and then everyone around them was forced to like quarantine for 2 weeks.
Yeah, well, a couple things. One is, sorry about that. One is that as the number of cases comes down in an area, there will be fewer cases that get into school. So people will just be less likely to get infected. So I think that that's just going to kind of take the temperature down on a lot of these school issues. In terms of masks, I think that outdoors, it's going to be less and less likely that masks will be required for anything. Indoors, I think that we're going to have to see what happens as cases come down quite a lot. You're going to have a lot of kids who are vaccinated, particularly in high school, so that'll be good. I would be surprised if there are requirements for kids to be vaccinated this fall. That I think will follow later if all the evidence works out in there. But you'll still have a lot of kids vaccinated, a lot of parents vaccinated. They'll just be much less likely for there to be a virus in schools. And I think that this, probably the recommendations are going to evolve based on what is actually seen. So you might start with masks in classes, but then if like nobody's getting sick and there's hardly any virus in the city, or it's really low, then it may be that the masks are even going to come off this school year. So I would say that certainly outdoor activities are much safer. Indoor, I'm guessing people might be a little bit more conservative at the beginning and then see how it actually goes. If there are a lot of unvaccinated kids, you could have a big outbreak, and because of the variants, you're worried that the kids could get sick. It's quite, it's within the realm of possibility that, you'd be in a little bit of the world like you were last year, where kids are wearing masks and there's testing and tracing and that sort of thing. But if I were to guess, I would say we'd be much more likely to be in the world where we're kind of leaning towards less and less of the restrictions, particularly as cases come down. A lot may depend on how many people in the city are vaccinated, because again, that will determine the number of cases, and fewer cases around, much less likely it'll come into the school.
My question is that, what is your opinion on the American health insurance system on like dealing with the pandemic?
Sure. So the American health insurance system is not really a system. As you may know, it's sort of a chaotic blend of all kinds of different things. About half the people in the country get coverage through their employer, and then you have a big chunk that get coverage through Medicare and Medicaid, and then you have a small number of people who buy coverage for themselves, and then you have still a bunch of uninsured individuals. And so it's a big mess. When this all started, I actually wrote an article saying we should have a special program for everyone in the country for COVID, because it's too much of a mess. Nobody took my advice on that one. So we wound up with a couple extra programs, that will pay for people who didn't, weren't covered. And I think that by and large, that's worked for a lot of people, but for a bunch of people, it hasn't worked. And there have been all these stories about people who are still getting charged for thousands and thousands of dollars for getting sick with COVID. And in general, the vaccines have worked reasonably well to be free, but testing was supposed to be free, but really isn't. All over the place, there are fees for testing. So I would give the US system a C- for responding to the pandemic. And systems that, are integrated, like South Korea's, I think did much, much better, making sure people knew they could get care, they could get testing without respect for, how they're, whether they're employed or, for example.
My question is, so recently, as we mostly know, that vaccines open to kids ages 12 to 15. And what allowed the government to make this decision? And do you think it would, if it would ever be necessary, be available to kids younger than 12?
Great question. So what happened was the companies did additional studies on kids 12 to 16. So they did the studies with tens of thousands of patients, for 16 and older for Pfizer, 18 and older for Moderna. And then they went and they did 12 to 16 with thousands of patients, not tens of thousands. And they looked to see what would happen. They saw a very strong immune response. And we've learned a lot about the immune response. We see the antibodies that kill the virus in kids. And when they looked, they saw 100% protection for the kids who got vaccinated. So there's no question that the Pfizer and Moderna vaccines work for 12 to 16. Let's talk about one additional aspect of safety, though, which is, I think, important to talk about, which is, and on that basis, they were authorized. Now, something that's important to know, and this is irrespective of this question of is it authorized or licensed, whether you do thousands of patients or tens of thousands of patients, how many people are actually going to get the vaccine? Millions and millions of people. So if you have a rare side effect, you will never see it in the clinical trials, right? If you have an effect that only happens once in 100,000 patients, you may not see it when you give it to 60,000 people or 40,000 people in the clinical study, or just 1,000 kids in the kids study. You're just not going to see something that happens with 1 in 100,000. But if you then go out and give it to 50 million people, you could see it 500 times, if my math is correct, right? So it's really important to keep watching for safety, whether it's licensed or authorized, and we're going to learn more and more about these vaccines. It was through that kind of oversight that we spotted the Johnson & Johnson problem. It wasn't because it was just authorized after 2 months compared to 6 months. You could have waited 6 months, you never would have seen it. It was because more and more people got the Johnson & Johnson vaccine and a rare side effect appeared. That the Johnson & Johnson vaccine is linked to strokes, particularly among younger women, and I think that is going to affect how that vaccine is used. Now, the reason I mention this is because you may have read that there's some reports of heart inflammation among young people, even after the Pfizer and Moderna vaccines. And those are also rare reports, and in general, everybody is recovering from those. But that's something that we will learn. We will learn more about the safety of vaccines as millions of people get them. I do think, and I have advised my brother who has kids, my kids are a little older, but he has kids in the 12 to 16 range, and he asked me, should they get vaccinated? And I said, absolutely, because I'm worried about the disease. And so everything is a balance between the disease and the vaccine. And I think the risks are very rare and low for the vaccine, but we'll keep learning about it. And so the benefits are very important. To your question about, so I think we'll see more 12 to 16-year-olds vaccinated, but this is one reason why I think I don't expect to see a lot of places require the vaccine for school until a lot more people have been vaccinated and there's a lot more known about the vaccine when millions of people are taking it, for particularly younger kids. They're now doing studies under age 12. So when those results come in, they'll look at those results, and I think they will start to authorize the vaccine for younger kids if everything is still going okay. So I would expect by the fall we may see the results of those studies, and based on those studies, possibly younger and younger kids being able to take the vaccine. The reason we started this one with much older people getting vaccinated is because the older people are at such high risk of death. But we go one step at a time to lower and lower age groups and make sure that it works and is safe. And right now, 12 to 16 it's open for business.
I had a question regarding India's outbreak. As you might know, India faced a huge surge in the past couple months. And I was wondering how you feel about the new variant there and if that could cause potential quarantines in the United States and its danger here.
Yeah, it's just a devastating situation in India. And it's a combination of a variant that is more transmissible and more lethal, and very few people vaccinated. The good news is the vaccines appear to provide a great deal of protection even against the India variant, which is good, or the variant that was found in India. So I think if people get vaccinated here, they're not going to be at high risk. But remember I talked that if not enough people get vaccinated, we could have outbreaks in the fall. I think, we know that these variants travel around the world. It's quite likely that it'll be here and could get a lot of people sick. So I think that's one reason why it's really important to get as many people vaccinated as we can now.
My question is, so obviously vaccines need to be distributed globally to truly end the COVID pandemic, but only like very few amounts are going to impoverished nations. So how can like richer nations such as the US catalyze this process?
Thank you. That was a very diplomatic way of asking that question. That was an excellent, important question and a very diplomatic way of asking that question because, you know, a lot of people are quite angry about this, that we have, you know, hundreds of millions of vaccine doses, but only very few have gone to poor nations. We're seeing the consequences of that in certain countries that are facing very severe outbreaks. To a certain extent, you could understand why countries like the United States wanted to get vaccinated because we had the worst outbreak of any place in the world. On the other hand, the planning for vaccinating the world didn't meet its expectations. There was a hope that people would share vaccines and that there would be global vaccination from the beginning. And those hopes have not come true. One of the major stumbling blocks is that there was a hope that the Indian manufacturers, because they can make millions and millions of doses, would really be the engine for vaccinating the world. But then a lot of their vaccine has been diverted to India because of the crisis that's there, and other countries can't get it. So I think there'll be a lot that's learned about what the lessons are for being better prepared from the beginning. But in terms of where do we go from here, like right now, what happens, it's a combination of things. First, there should be vaccine donations, and you're starting to see those from other countries, including the United States. Second, there has to be a commitment to making more vaccines for other countries. And third, we have to build manufacturing capacity around the world so that other countries aren't dependent on, say, the United States for all their vaccines. There should be regional manufacturing so that they can respond quickly within their own region. And that's a lot of work to do, but it's going to be very important for the next pandemic as well as this one.
So my question is, earlier you mentioned that studies were conducted for kids to take the vaccination, like ages 12 to 15, with both Moderna and Pfizer. But I'm wondering, like, why is only Pfizer offered to kids ages 12 to 15 if both were tested on?
Got it. I can answer that super fast. The Pfizer was first. The Moderna their studies took a little bit longer. So I will fully expect that shot will be available for 12 to 15 very soon.
My question is, how do you balance public health measures and pursuing them with other elements in society, such as like the economy?
Very carefully. It's very important to think about that. And one quick point to mention there is you should identify the friction points between public health and the economy and invest to make them less tense, to basically address that issue. So for example, if you have to close bars because of COVID, because everyone's laughing and drinking and, you know, it's going to spread COVID, then you should spend money to support the people whose livelihoods depended on bars. You know, so you try to put resources at those tension points in order to accomplish both things better.
Wondering about how I've read some things about how masks have made flu rates a lot lower this year in the past couple of years that we've had COVID. I was wondering if, from an epidemiologist point of view, that masks should be continued even once the COVID crisis has passed.
So very quickly, there's going to be a forecasting center for pandemics, kind of like a weather service. And they may say like, well, today, you know, like a weather service might say, bring your umbrella to school. They may say, today, wear a mask. So it may be this week, we're recommending masks in Cleveland and Buffalo. So that's potentially ahead of us.
Real quick, my question is, I've heard that like pandemics as a whole will start happening more and more often. I think every 5 years is the most shortest estimate. So what do you think about that?
I have no idea. I've heard that too, but I do not know. And I hope that doesn't happen. But I think we have to be prepared.
So right now there's a lot of news on finding the origin of the coronavirus. So even if we do find a definite origin, does this really matter to us?
I think it does matter, because I think it could really help us understand where future coronavirus pandemics could come from. If it does turn out to be the lab, I think it could have huge implications for the kind of research that we do on viruses. So I think it does matter.
Hi, my question was, do you ever think the United States government will make vaccines like 100% mandatory for all citizens? Like students can't go to school without wearing masks if they're not vaccinated.
Well, states do make vaccines required for school. Like, you have to get measles in every state, I think. If not almost every state, probably, the measles vaccine. So at a state level, you can do that. The federal government really can't do that under the law. I'm not sure. Let me just say, I think there'd be some big questions about whether the federal government could mandate that, but states could for certain things. There'd have to be a very strong rationale, and there probably would have to be some protections for people who, for example, medically can't do it or have a religious objection. So this is an interesting question of public health law, and there's some very interesting cases. And now I'm blanking on the case in Massachusetts, which you could find a very important case that talked about the ability to require vaccination. So it's possible, but there's a whole legal structure that has to be put around it at the state level.
I was wondering, when you spoke about young children and them getting vaccinated, what about younger children having like a fear of needles? Like, would we look for maybe an alternate mode of administering the vaccine for younger children?
I think that there are all kinds of different interesting technologies for this. Let me just say to the previous person, I don't think we're going to, even though while I was talking about the legal authority to require vaccination for everyone, I don't think we're going to see that for COVID. I think we're going to do a good enough job controlling this through voluntary that we're not going to have blanket vaccine requirements. I do not think that's going to happen. So your question was about vaccines. Kids need vaccines. Kids get all kinds of vaccines, and they get them by needles, and there's a lot of research to figure out alternative ways to do it. And having given a lot of kids vaccines myself, because I'm a pediatrician, I will be all for alternate ways. But until we get there, we're just going to have to vaccinate kids to help them.
Hi, Dr. Sharfstein. So I had a question about testing. I think you mentioned how the 12 to 15-year-olds had a 100% immune response to the vaccine. How do they quantify the response and the efficiency?
So what they found by 100% is that when they looked in the study to see who got remember before I said 95 versus 5? For kids, it was 100 versus 0. All of the cases of infection were in the placebo group, and none of them were in the vaccinated group. So now that doesn't mean a kid could never get infected, but in the study, they didn't find it. And they quantify that. So they're actually looking for kids who are getting sick in that study. That's basically what they do.
Hi, my kind of going off what someone said earlier, how pandemics may be happening more often. My question is, what type of legislation do you think we should implement so that we can more quickly contain a future outbreak and strengthen our infrastructure?
Well, that's a great question. That's a reason we have to be really thoughtful. I think there are things that have to be done for pandemics specifically and things that have to be done more generally for our public health system. We need to have better surveillance, a more fair, better access to care. Then you have platforms like the RNA platform should be more readily available around the world. We need to be able to set up clinical trials quickly. So there's going to be a huge agenda. The one thing I would point out when you're reading stories about this huge agenda, think about which things really don't matter until there's a pandemic. I mean, we need some of those. And which things are really important even now. So we could save a lot of lives now if we gave sick leave to people so that fewer people got sick in the workplace. It would be great for everybody, and it would put us prepared for the next pandemic. So which things are good now plus help with the pandemic? We need some of those, and we need things that are just special for the pandemic, like a special lab or something.
I just wanted to ask about how multiple states are removing the mask mandate, and what do you think about that, and why do you think they're doing that?
Well, in some cases, I think it is getting to be appropriate. I think a bunch of states jumped at it too quickly, in my opinion. In my state of Maryland, the governor did it, but a bunch of counties kept it going, I think for good reason. So I think what really matters for the mask mandate is not whether if you're vaccinated, you don't have to wear a mask. I mean, that's a good thing, but that's not the most important thing for a mask mandate. Going back to my car analogy before, the most important thing is how many cases there are out there, right? If there's very, very few cases, I think we can feel more comfortable without a mask mandate. If there's still a good number of cases, then I think it's important to wear masks indoors. That's going to be the big difference for me.
Hello. So I was wondering about should states in the United States and countries around the world, should they implement a system with having vaccine passports before entering public vicinities and facilities? And
So,
I know some states in the US have banned it. So what's your take on it?
so what are vaccine passports? There are two aspects to vaccine passports. One is proving that you were vaccinated. Just can you prove that you were vaccinated to someone? Right? Those little cards aren't really proof. Those cards can be, forged. Is there a way to actually prove 100% that you're vaccinated? That's one part of the passport. The second part of the passport concept is how that proof might be used. Okay, so this is how I think about it. I think it's totally legitimate for people who have gotten a medical treatment like this to want to be able to prove that they're vaccinated. I want to be able to prove I'm vaccinated, that and for all kinds of reasons, for my medical treatment, for other things. I think it's it's totally fair for people to be able to show that they're vaccinated. Let's say a group of parents want to get together to talk about an issue at their school and they want to have a meeting inside. Then the parents could say to each other, hey, could you prove that you're vaccinated? We could all meet in person. I think that's totally legitimate, like just to be able to show you're vaccinated. The second question is, well, how does that limit you? How's that going to be used? And I think that we could imagine some uses of that are fine and some uses of that make you uncomfortable. Okay, and so you have to figure out where you're going to draw the line. Back to the question of ethical questions. This is a good ethical question. So what would be a use of this that's fine? We want to have a concert of all these people jumping around indoors, screaming and shouting. Well, maybe it's okay for that. It's a private business. I think it's completely legitimate to say you have to be vaccinated to come into this closed space because we're going to protect everybody who's there. And it's an optional thing. If you don't have to get vaccinated, but if you want to go to the concert, you have to get vaccinated. To me, that's reasonable. Other people could disagree. Now, on the other hand, what if you said you can't get a driver's license? You can't go to the MBA unless you're vaccinated. I would have a problem with that. I think that getting a driver's license is really important. It's something people should be able to do. It helps them earn a living. And I think it might be kind of too much of a use of state power to say you can't come in there without showing your vaccine passport. So for me, I think there's like a line to be drawn. There's certain things that are okay, and it really should depend on whether it's really necessary. And the countervailing thing is is this really important for citizenship? I don't think your citizenship really should depend on whether or not you are vaccinated in quite that way. I don't know if that makes sense, but that's how I kind of think about it. But I don't have a problem with people being able to prove that they're vaccinated.
My question is that I noticed that the United States is sending vaccines to other countries. And regarding this situation, how much vaccine and through what process does the US send vaccines to other countries?
Sure, there are a couple ways they can do it. They can do it directly and through a organization called COVAX, which is kind of assembling vaccine for other countries. So I don't know exactly how the unilateral decisions are made. I know that COVAX has a process and a formula that they use. So if the US is doing it through COVAX, there's a whole process, and you can look that up.
So my question is, some people have stated that although the United States healthcare system is expensive, other healthcare systems, such as the one in Canada, do not allow for greater technological growth and innovation and the widespread use of state-of-the-art medicine due to a lack of funding. They state the example that medical technology often gets more expensive and larger as opposed to other technologies like cell phones. If this is true, how does this relate to the effectiveness of the United States pandemic response, i.e., getting medical equipment to hospitals or getting more effective vaccines?
Sure, and very well thought out, interesting question. Each healthcare system has its strengths and weaknesses. The United States spends so much more than any other country on healthcare. And by and large, there are a number of countries that have quite a lot of high-tech healthcare. not just the United States. So I think you have to judge the system kind of from multiple dimensions and in different ways. In the United States, I think that there are certainly some patients who got just absolutely sensational intensive care unit care. And that's great. Certainly people in other countries got very high-tech intensive care unit care. Maybe more people got very high-tech intensive care unit care in the United States. But this is a good question to end on, because from my perspective in public health, the most important question is how many people got really sick and died. And we can't over-rely on our healthcare system. We can't say that our goal here is for the healthcare system to just take the most technological care of people and we don't care how many people get sick, because what happens is we get more deaths. And the United States has really suffered from that we've over-relied on healthcare. We've invested a lot less in prevention, a lot less in public health, testing, tracing, and outreach for vaccines, all those components that are necessary to keep people from getting sick. And as a result, we suffered so many deaths. I think we're like at 600,000 deaths or something like that. Just horrifying. And a lot of those were unnecessary. So I think we have to be worried, we absolutely need a high-tech healthcare system, but if that's all we focus on, then we ignore all the people without insurance. We ignore all the opportunities to prevent people from getting that sick in the first place. And our goal with healthcare has got to be more than healthcare. Our goal with healthcare has got to be health. We want a healthier country. We want fewer people dying. We want longer life expectancy. We want people to grow and have a future and do the things that they love, without worrying about a horrible preventable disease. And it's not a lot of consolation to say, your child or your parent got this horrible disease. It was totally unnecessary. But the good news is they're going to get this really high-tech treatment, because, those treatments aren't cures. I'd rather not have them sick in the first place.
Thank you.
Sure. So, can you still see me here, Siam?
Yes, we can. Yep.
Okay, I just want to say that I've had a companion for this talk here, my dog Luna, and she appreciates all of your patience to stay to the very end. Right, Luna? Luna loves looking into the camera.